Hello guys, welcome back to the channel Med Pharmaco Essentials. Excited to share my third day experience in the Department of Psychiatry. So our duty, as usual, started by signing the register, marking the attendance in the ward, as that is the most important part of our internship. Then we had to meet our senior resident under whom we were posted, that is Dr. Anusha ma'am in the psychiatry. There was an ADR being seen in the patient, that is of increased sedation. So, ma'am said to just assess the case so that we will know the reason what was the increased sedation, why the patient had increased sedation. So, we just went to the patient, took the previous medication and medical history. Then we had stood there for almost 2 hours because it was a very long history actually. The patient was having the psychiatric illness from 10 years. So the four main drugs we came across during that history was THP, Duxetin, then clozapine, then risperidone. So then after taking history and interacting with the patient, we started to assess the case. Found drug interactions, we found the adverse effects, we saw for the dose adjustments, almost assessed all the parameters of that patient. Then learned a lot actually by practically seeing the patient with an ADR and knowing about the case and all the thing. Finally, found two typical antipsychotics were being prescribed to the patient. He was under two atypical antipsychotics. That is, one is risperidone and second one was clozapine. That two actually have an ADR of increased sedation, or you can say, or dizziness. So that was the two drug that could cause the patient this same thing. Then that included, he even had increased intense headache, memory disturbances. He could not remember most of the things. He had excessive sleepiness and even blurred vision. Then it was decided to slowly stop the risperidone because he had taken up to max of 8 mg also it has gone for so many years. So the dose of risperidone was slowly reduced, and then clozapine was given in the minimal doses to manage the symptoms. Basically, that case was about paranoid schizophrenia, where the patient was very irritable and he had a poor self care. He was hearing voices in his ear, so he could not concentrate in his work due to hearing of those voices. Then whenever he see a group of people, no, he will think that they are speaking about him only and go and fight with them. Even with the family members, he has done the same thing. He thinks that his family members are going to harm him for the property purpose. Then he would always fight with him actually. Then he could talk to himself also, looking at the walls window for a very long time, and he would just go out and check for sometimes. So he would just roam out sometimes. Then he would be unable to work or concentrate in his work due to hearing of voices in his ear. So that was his complaints and history of his presenting illness. It was actually a very good learning experience there. I'll just discuss in the next video about whatever interactions we have found or areas we have found or counselings we have done. Thanks for watching the video.